Ya estamos en vivo. Buenos días, continuando con el programa de hoy, a nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, Chairman del World Congress of Neurosurgery UNESCO ASPNet Walter Tandy, in honor of Professor Yaşargil, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capicasillas, Chairman del capítulo estudiantil ASPN, al doctor Salim Abdurraf, Chairman de Walter Tandy Neurosurgical Society, al doctor Babak Ateb, Chairman de la Society for Brain Mapping and Therapeutics and the Brain Mapping Foundation. Todos ellos vice-chairmans del comité organizador, y al doctor Parménides Guadarrama Ortiz, chairman del Centro Especializado de Neurocirugía y Neurociencias México. Es para mí un honor presentar la siguiente ponencia a cargo de la doctora Mirna Sobana, quien es miembro de la Asociación de Médicos de Indonesia, miembro de la Asociación de Neurocirugía en Indonesia, miembro de la Federación Mundial de Sociedades Neurológicas y jefe de la División de Neurocirugía Pediatra, quien nos hablará el día de hoy sobre hidrocefalia como uno de los problemas de salud global emergentes, perspectivas presentes y futuras en neurocirugía. Doctor Sebastian, please.
Is it my turn?
I believe Dr. Sebastian, maybe he cannot hear us. I will introduce you. My name is Dr. Ahmed Assasa. I'll be the mediator for today's presentation. And today, Dr. Mirna Sobana will be presenting. She's a neurosurgeon at the Chief Division of Pediatric Neurosurgery, Hassan Tariqin General Hospital, Sharan University, the Faculty of Medicine. She's also a reviewer for the Child's Nervous System International Journal and the lead reviewer for Child's Nervous System International Journal. Dr. Mirna Sobana, you have the mic.
Okay, thank you very much for the opportunity for me to speak in this event. I would like to share my screen. Is it already full screen of my presentation?
Yes, doctor.
Can you see it?
We can see it.
Okay.
Yeah.
Okay. Okay. I would like to talk about pediatric hydrocephalus. Why would I talk about this kind of title? Because pediatric hydrocephalus still be as one of emerging global health problem since our last time, and then in present and the future perspective in neurosurgery. Okay, so yeah, I can move my screen. Okay, because why we talk about this? Because we want to improve the lives of children with hydrocephalus. In the global hydrocephalus epidemiology and incidence, the research by Michael Dewan and Professor Benjamin Wharf and et al., the pool of incidence of congenital hydrocephalus, the highest seems to be in Africa and Latin America, but yet we don't know exactly what about in here in the Southeast Asia or in the Asia. Well, actually, I don't think they all have data about our situation here in Indonesia. Can you see my pointer?
Yes, doctor.
Yes. This one is Indonesia. Indonesia is lies between the Asian continent and then also the Australian continent. Here's my country. Here's Indonesia, consists of many islands. And then they say that the lowest is in United States and Canada. I believe that the data is maybe valid because the HCRN research, multicenter hydrocephalus research has already done in the Southeast North America. But the most common causal mechanism in high-income country are post-hemorrhagic hydrocephalus of prematurity, and then congenital aqueduct stenosis, myelomeningocele, and brain tumors. While in the middle low-income countries, infection still become an issue. Here, sorry. here is my our hospital. It's Hasan Sadikin Hospital. It's we are live in Bandung. Bandung is in West Java. Java is here, and Bandung is in the middle of in the western of the Java Island. Here is Java Island, and here is our hospital, Hasan Sadikin Hospital. We have the data in children with hydrocephalus since 2014 until 2020. We have 833 patients, which is the demographic, the age, the ratio between male and female is not, it's slightly different. And then the age is, the most age is under the 1 year old. And then after 10 years old, the number becomes decreased. And then the GCS while entering is usually mild. And then in the different conventional classification, we found that communicating hydrocephalus is minor than non-communicating hydrocephalus. This is the classification in the conventional classification. And we have Kahle classification, which is acquired hydrocephalus and then congenital hydrocephalus. I will mention about the detail later. The acquired hydrocephalus seems to be major, a lot more than the congenital hydrocephalus in our center. And then we have our own classification, is the infectious hydrocephalus and non-infectious hydrocephalus. The non-infectious hydrocephalus seems to be more than infectious hydrocephalus. And our management for hydrocephalus, we usually do VP-SAN. Is it VP-SAN is superior, or EDV is superior, or EDV plus CPC is superior than other treatment? We will see later. Okay, what is the definition of hydrocephalus anyway? The definition of hydrocephalus is slightly changes in the years. Since 1914, Professor Walter then began a multi-decade study on the pathophysiology hydrocephalus, and then the developmental he did the developed experimental animal models to study pathophysiology of hydrocephalus, and they found that choroid plexus as the site of CSF production. They classified hydrocephalus into two types, is communicating and non-communicating. That's why I call it the conventional classification, communicating and non-communicating, because right now the classification is more details, and then we will see that later in my presentation. And then in 1915, the development of the valve-regulated has and the SAN invention led to marked increase the desire to understand the condition of hydrocephalus. In 1960, Rosenhoff reassessed the Dundy's classification. He said that all hydrocephalus involve the obstruction of the CSF flow between its point production of the ventricular system. And they renamed the non-communicating hydrocephalus as intraventricular obstructive hydrocephalus, and the communicating hydrocephalus that was caused by obstruction at the level of basal cistern or arachnoid villi was therefore called extraventricular obstructive hydrocephalus. And then so many changes in the definition and classification, and then we found the latest, nearly latest, the Professor Recate, 2008. He said that he assumed that all of hydrocephalus is assumed as obstructive unless the tumor, the choroid plexus tumor. He said that only two types, all the hydrocephalus is obstructive unless the tumor of choroid plexus. The definition was he presented in a meeting in Hanover, German, in September 2008, like this, and after 2008, he also said it in his study in 2011. This is the same. With the exception of the rare case of choroid plexus papilloma overproduction of CSF, all hydrocephalus is obstructive in nature. Okay. You can see the pathophysiology also have a dynamic changes and in the knowledge and studies. Classically, the obstruction of CSF flow within the ventricle is classified as the obstructive or non-communicating hydrocephalus, whereas the obstruction of the CSF flow its absorption in arachnoid spaces is known as communicating hydrocephalus. Okay. Here's the artist depiction of the circuit of the heart as the battery. The heart is pumping the artery and then to the cerebral microvasculature, and then there goes to the choroid plexus and to lateral ventricle to the foramen Monro, and then entering the third ventricle. After the third ventricle, entering the aqueduct sylvi, and then entering the fourth ventricle from foramen magnum, and then lateral foramen, entering the spinal subarachnoid space and cortical subarachnoid space, and reach the arachnoid granulation, and entering the vein, the sinus, and return to jugular foramen, and return to the heart. And then from the Rickett 2008, and then he also citing the paper himself in 2020, the aqueduct obstruction seems to lead the trilateral ventricles. So the third ventricle and lateral ventricle become enlarged. Okay. I skip this. And then Professor Rickett in 2020, he divided the obstruction of the obstructive hydrocephalus into five types, depend on point of obstruction. The point of obstruction would be in foramen Monro, aqueduct sylvius, fourth ventricle foramina, spinal to the cortical cerebral arachnoidal, and then the arachnoid villi, and then venous hypertension. It could make the hydrocephalus. Okay. The differential diagnosis of the obstruction in foramen Monro, the causes could be tumor, congenital abscess, just like stenosis of the foramen Monro, and then ventriculitis that could block the ventricle, just such as the multiloculated ventriculitis. It could be blocked the foramen Monro and or the functional matter. The aqueduct sylvi could be blocked by tumor or birth defect, such as aqueduct stenosis, X-linked aqueduct stenosis, or secondary to ependymal denudation, or the disruption of the osteospondyn subcommissural or in the subcommissural organ. And the fourth ventricle foramina could be obstructive by infection, tumor, or fossa posterior tumor, or severe chiari malformation. The spinal to the subarachnoid spaces could be blocked by subarachnoidal hemorrhage, and arachnoid villi could be blocked by hemorrhage or infection, and venous hypertension could be blocked by venous thrombosis, congenital hydrocephalus, or pseudotumor. And the treatment available are stents, can be stents, or like the septostomy, endoscopic fenestration, or shunt, EDV, ventriculoperitoneal shunt, or lumboperitoneal shunt, or doing bariatric surgery or prosthesis. Which one is superior? We still don't know, but it depends on the cause of the hydrocephalus itself. And the classification, we know the classification from Dr. Christopher Kahle, Abdaya Kulkarni, and Professor Benjamin Warf that presented in Seminal and SEP 2016, that published online on August 7, 2015. The hydrocephalus divided into two groups, acquired hydrocephalus and congenital or developmental hydrocephalus. The acquired hydrocephalus is also divided into three groups of inflammatory, neoplasm, and vascular. The inflammatory could be hemorrhagic or infection in the subarachnoid, or inflammatory could be intraventricular, can be caused by hemorrhagic or infection. And neoplasm could be in parenchyma, cranial tumor, disseminated tumor, choroid plexus tumor, of course, or choroid plexus tumor or hyperplasia. And vascular acquired vascular disease could be vascular malformation such as ventricular obstruction, just like vein of Galen malformation, venous hypertension, or AVM. And there could be the problem could be disorder of cerebral venous function, could be extrinsic venous obstruction or intrinsic venous obstruction. In congenital or developmental hydrocephalus, we usually see it in the as congenital aqueduct stenosis and neural tube defect. We can see in the spina bifida, like myelocele or lipomyelocele, and Chiari-2 malformation. And then we can see the fossa posterior malformation, such as the Walker malformation, developmental cyst, and also could be found as congenital foramen Monro atresia. Here we have some data in our center. I classified, I do classification for hydrocephalus and then divide into two groups: infectious hydrocephalus and non-infectious hydrocephalus. The infectious hydrocephalus, we divided into the serous meningitis, bacterial meningitis, and viral meningitis, cerebral abscess, and post-infection hydrocephalus. But the number seems to be minor than to the non-infectious hydrocephalus. Non-infectious hydrocephalus, most of them are congenital hydrocephalus, and then the second place is because of the intracranial tumor, and then the third place would be accompanied the neural tube defect, and then because of the germinal matrix hemorrhage or intraventricular hemorrhage could be causing hydrocephalus, and also the last one is aseptic meningitis. The aseptic meningitis could be caused by tumor, the malignancy. Here is from the Kahle classification. It's more complicated. Here from the inflammatory, we divide it as subarachnoid and intraventricular. The infection, hydrocephalus with infection seems to be major, in a major number, more than 180 patients. And then the acquired hydrocephalus, it seems to be the parenchymal brain tumor would be in the first place. And then the vascular malformation is more than a disorder of cerebral venous, or we don't find any disorder of cerebral venous. Maybe because we are in the younger age, in the last time, years ago, we didn't do a lot of endovascular endovascular surgery or endovascular imaging, just like DSA or something. We don't do that, and we are very it's a little bit difficult for us to do MRA, CTA, or DSA. But nowadays the DSA is already performed in our center, so I hope the data will be we can see the new data of it maybe after the pandemic is over, the data will become a rise. And then the congenital of developmental hydrocephalus, the neural tube defects would be in the first place, about 90 patients, and then the aqueduct stenosis is the second place in our center. What about the clinical presentation of hydrocephalus? We can see in the earlier age, prenatally before, we don't have to diagnose hydrocephalus after the child has already born, but we can see the fetus prenatally by level 2 ultrasound scan. The level 2 ultrasound scan is also known as an ultrasound that usually performed in a with child mother, which is around 18 to 20 weeks of gestation. It's usually done in the North America or maybe in another country, but within our country, I talked to the OBGYN. They said that they still don't do that, but I believe if we have agreement, they could do the level 2 ultrasound to detect the anomaly of the anatomy in the anatomy of the fetus, and then yes, we can do the fetal MRI, but in our center usually not as the screening, but the third screening we usually do that. But the amniocentesis is invasive procedures. It could be cause infection, so we don't do that unless if there's suspicious thing in the fetus. We do the amniocentesis. If we don't do that for screening, but I guess the level 2 ultrasound scan should be performed in any center. And from infants, we can see after the baby born, we can see the abnormal increase of the head circumference. The baby could be irritable, and then vomit and bulging of the anterior fontanelle and swelling of the cranial suture. The vomiting, bulging of the anterior fontanelle or irritability is usually in the acute hydrocephalus. In the congenital hydrocephalus, usually the abnormal increase of head circumference and swelling of cranial suture is more major seen in the congenital hydrocephalus infant. And in the hydrocephalus in baby or in a child over 1 year old, the clinical, we can see headache, vomiting, irritability, loss of developmental milestone, diplopia, or cranial nerve palsy, or and then papillary edema. Here we can use the measurement of the head circumference and ventricular index. The head circumference you can easily using the measurement the elastic not elastic usual measurement, just like the Taylor that we use to measure the head circumference. We can use this index. we can see the head circumference even for the premature baby born. We can use this measurement if the baby is premature, and the WHO diagram can be used for a baby in within the aterm, in a normal aterm birth. This can be used in the preterm birth, and we can use the Levin index, ventricular index, to see the if there's any enlargement of the ventricle. So if the head circumference remain in the same or in a normal line of the graphic, this graphic, and then but if the ventricle index is become crossing the 97%, it could be hydrocephalus, even if the head circumference is seems to be normal. But if the Levin index is more than 97%, we can be suspected as hydrocephalus. The same, there's a difference between boys and girls in this graphic. And here is the measurement of the Levin index. Levin index is the distance between the falx and the lateral wall of the anterior horn in the coronal plane of the level at the level of third ventricle. Here's the third ventricle, and this is the falx, considered as the falx, and this is the lateral wall of the anterior horn. And then we measure it. If there is 4 millimeter above the 97th centile, it could be considered as suspect of hydrocephalus. Okay. And probably it's indication for neurosurgical treatment is independent of the birth weight and other consideration of infant's condition and age, like extracranial matters. If the baby is in the optimum condition or not for doing procedure of shunting or anything. Here's the WHO measurement. The diagram is like this, but it seems to be the baby is in a normal age at birth, in the aterm age, and the last in the Levin index is for preterm baby. And the brain imaging, because of the danger of the X-ray, the X-ray in a newborn baby, we consider to follow up the baby by ultrasonograph. Ultrasonograph can be used in utero or for newborn or infant with open fontanelle. The MRI is preferred to avoid radiation exposure and provides more information, but in our center, MRI is very expensive and we have to wait for MRI about 1 week to 2 weeks or maybe month, or sometimes the MRI is broken, so we cannot use MRI. But for CT, to do CT scan, we are afraid to give the baby exposure to the X-ray. So we decide to do serial ultrasonograph within each week or 2 weeks or 10 days. And then for sign MRI, we can see the CSF flow, and we can see the changes of CSF hydrodynamics in a special case, the site of obstruction is present. We can see the site of questionable obstruction, and then could provide the efficacy of treatment. But the sign MRI is not available in our center. It needed more than 3 Tesla MRI, and then we have already got the new MRI, but the MRI they say that the MRI cannot see the CSF flow. I don't know, maybe the software is not available yet. And the treatment of hydrocephalus. What is the best treatment of hydrocephalus? What do you think? The best treatment? Is it the sun? Is it EDV, or is it EDV and CPC, or pharmacology? Have you ever heard of pharmacology, or the cell therapy? Where are we now, and what is the best for us? However, the derivative surgery doesn't reverse the inborn brain defect. This has led the study group on hydrocephalus to conclude that in the 50 years after introduction of chance for treatment hydrocephalus, we must acknowledge that the sun is not the cure of hydrocephalus, isn't it? The Berg Snyder and et al. Said this in their paper. The title was "What we don't but should know about hydrocephalus" in 2006. But it seems to be maybe this is still to be questioned until now. We can see the CSF sun in the early 20th century. The hydrocephalus surgery was done by open craniotomy, and then they tried to do crude endoscopic method, but unacceptable, except the morbidity and the mortality. In 1952, Nelson and Spitz first report the creation of sun-diverting hydrocephalus, the CSF, from the ventricular system to jugular vein to successfully treat the communicating hydrocephalus. And then in 1960s, they tried to make the thoracic tubing valve mechanism, and then they invent so many valve mechanisms and CSF diversion, just like EVD, subgaleal hemorrhage, and then shunting. We can see there are so many kind of shunting, but most commonly is ventriculoperitoneal shunt. And then if we cannot do the ventriculoperitoneal shunt, the ventriculoatrial shunt or ventriculopleural shunt could be another choice, but should be very the patient selection should be very selective. And the silas tubing is generating to valve mechanism, and then they invent the flow regulating valve mechanism, and then now we can see the anti-siphon or gravitational devices. And we can see right now there's a programmable shunt also available, but very, very expensive. Here's the procedure that commonly we know is ventriculoperitoneal shunt. We can enter the ventricle from the culture point or from kin point. Usually the kin point is desirable for the patient with the fontanelle anterior still open, and the valve is usually placed behind the ear, and then long catheter entering the peritoneal cavity. Here we can see we use to measure the opening pressure of the ventricle is a must in our center. We do it by do-it-yourself pressure measurement. We use the Abocas, we use the EVD set or the or the catheter into the peritoneal cavity, into the ventricular cavity, and then connected into the abocate, and then the infusion set, and then we measure it, so we can see that the pressure is in centimeter H2O. And then we have another manometer, another thing we can connect it into the manometer, and then we can do it more accurately. We hope it's more accurate than this one, but we cannot use this all the time because the connection between the ventricular set to the manometer is hard to find, so we usually use this one rather than the manometer. And sometimes we do the programmable pressure, programmable shunt, or adjusting pressure valve in the very certain in a very special patient with the very selective, because usually the patient has no money, and then we use the national insurance program, but they don't usually approve the programmable shunt because of it's very expensive, and we have to be very selective to use it. And this is ventricular arterial shunt that we do if there's a problem in the peritoneal cavity. We can do the ventricular arterial shunt also with a very selective patient with no there's no problem in their heart or in the jugular vein. And there's also, and we do also the third ventriculostomy. I want to share something about the third ventriculostomy, the EDV. Is it EDV superior than VP10? Do you think so? Or EDV plus CTC is superior than VP10? I think it's still it's still a question, because there's still so many studies that ran with by the scientists, even for the very big hit scientists. In 1910, Vincent Darwis is a urologist, do the first choroid plexectomy using the cystoscope to fulgurate it. They do it. He done that to 2 patients. One died and other lived for 5 years. And then Walter Dandy performed the several procedure for hydrocephalus in 1918. The first open ventriculostomy done by fenestrating the lamina terminalis through the transfontanel approach. And in 1922, unsuccessfully attempt choroid plexectomy using the ventriculoscope or ventriculoscopy. I'm sorry, I don't have any picture of that. And then in 1920, William J. Mixter is the first successful EDV done. So EDV first time is 1923. And then 1978, Price done the series of 5 patients who had treated with EDV using the fiber optic endoscope. And then the new age came in 1990. The Jonas et al. Reported 50% successful outcome from EDV in 24 patients with non-communicating hydrocephalus with 8 morbidity, and there's no mortality in the outcome. Where is the EDV? EDV is placed here. It's to bypass from third ventricle to the space to the somewhere between the spinal subarachnoid space and cortical subarachnoid space. Here is in the basal cistern, and this you might be very already know about this kind of procedure from the culture point. We enter, or we can be moved forward to the frontal area, and then we enter the lateral ventricle, and then passing through the foramina of Monroe, and then we can see the floor of third ventricle, and do the ventriculostomy in the third ventricle to the prepontine system. Here is in the early 2000, the EDV is added by CPC. The EDV plus CPC was carefully investigated by Professor Benjamin Wharf in Uganda, and considered as the promising results of hydrocephalus in various etiologies, including post-infectious, non-post-infectious, post-hemorrhagic, aqueduct stenosis, meningomyelocele, and then the Walker complex. We can see there seems to be the failure-free of survival pattern of EDV and SUN. Here, the EDV failure rate is lower than SUN. There's also the treatment after years. This is for SUN, and for EDV, it seems to be lower. In 2011, the largest published North American experience to date comes from Benjamin Wharf himself, in early reported at 2011. 4 of 10 infants with post-hemorrhagic hydrocephalus of prematurity were treated successfully with EDV plus CPC. But here, in the study by themselves from Dr. Abaya Kulkarni and also Abaya Kulkarni himself, he's in the same team with Professor Benjamin Wharf. This is the prospective study by the HCRN, Hydrocephalus Clinical Research Network. It's the multi-center study. They said in conclusion, within the large of board cohort in North American infants, of the data show overall EDV and plus CPC appears to have higher failure rate than SUN alone, although the EDV plus CPC results were similar to EDV alone. This comparison was limited by small sample size and skewed etiological distribution. Within the EDV plus CPC group, greater extent of CPC was associated with treatment success, thereby suggesting there are subgroups they might be benefit for addition of CPC. So they think that the EDV CPC is not significantly superior than SUN alone, or even with EDV alone. They said that they need a bigger sample size. So we can see here that the clinical research network of hydrocephalus in many multi-center in North America, I guess they need bigger sample, maybe worldwide or multi-center or worldwide collaboration. And here the global hydrocephalus epidemiology and incidence systematic review and meta-analysis. You can see here they say that yeah, we can admit that in our country here the research of hydrocephalus is still low, but we have a dense of population here in the West Java. The source of data, the shaded dark purple here is they have many research in North America and then also in China, and then maybe in South America there's data here in maybe Uganda, Kenya, which is they lead by the North America, sure, with North America also, and in the England. But here in Indonesia, still very few source of data. But we are now ready to collect the data, and we can contribute to the international resource of data of hydrocephalus. Here is our country, and this is West Java. This is where we live. West Java is the most dense population in Indonesia. We have more than 40 million people here, and about 10% of that is child, is a toddler or child below 5 years old. We call them balita, and it's about 20% is children below 18 years old. Here is our data. Pediatric is 12.6% of the population. Is our data for pediatric population is 16 million, nearly 16.5 million people. In West Java here is very big. It's very big source of data, and we can see the epidemiological study here in West Java. Here, what about the outcome? The outcome we can see not only in the acute condition or in the perioperative condition. We have to study the hydrocephalus patient in the long-term neurodevelopmental outcome. Here's our article that published in Child Nervous System in 14th of January this year about the neurodevelopmental outcomes after ventriculoperitoneal stent placement in children with non-infectious hydrocephalus as a meta-analysis. And here's our result. We can see there's so many risk disability after stent placement in congenital hydrocephalus in non-infectious children. You can see the cerebral palsy. There's a risk of disability, one of the risk disability, and then visual impairment, hearing impairment, and epilepsy. The child with congenital hydrocephalus that acquired stent non-infectious was 8 times higher higher risk in cerebral palsy compared to normal population, and they have 3.9 times higher risk of visual impairment, and then 4 times higher risk of hearing impairment. But there's a very I think this is huge number of the risk of epileptical seizure or epilepsy or seizure in stunted hydrocephalus in an infectious patient is about 16 times more than the child, the normal child. It's 15.75. This is the most. So we are still follow up this our study, and then we will continue our study to see why the epilepsy or seizure are having more risk in the child with hydrocephalus, even if they are already stunted. And here we have come to conclusion that the children with hydrocephalus is tremendously important in public health concern or in the global concern. And studies about hydrocephalus is very dynamic and yet challenging. We still have to find out how to treat hydrocephalus. Is it SUN or EDV plus CPC, pharmacological or targeted cell therapy? Or yes, the sample should be worldwide and very for every study need a very big sample, and multi-center or even multinational worldwide collaboration would be needed for the hydrocephalus study. Thank you very much. Terima kasih, hatur nuhun. This is Indonesian language and Sundanese language, and this is our hometown in Bandung, West Java, Indonesia. Thank you very much.
Thank you, Dr. Mirna Sobana, for this interesting presentation. I have a couple of questions, if you don't mind. One of my questions is, what is the probability for an adult to develop hydrocephalus? Is it a high probability or a low probability for an adult to develop hydrocephalus?
In infection? I'm sorry, I couldn't hear you clearly.
What is the probability for an adult to develop hydrocephaly?
Oh, adult has hydrocephalus. When adult has hydrocephalus, it should be not the clinical problem is not the head become enlarged, but it soon would be deteriorated. Usually in the adult hydrocephalus, usually it might be acute hydrocephalus, or in the elderly it could be NPH or normal pressure hydrocephalus, because the atrophy or the some kind of like dementia or geriatric problem. But usually in the young adult, caused by, here in our country, is caused by cirrhosis meningitis because of TB infection. That could be making the inflammation of the ventricular wall, and then make it there's disturbances there until there became hydrocephalus because of the cirrhosis meningitis, like that. Usually cirrhosis meningitis or tumor is in the second place, and then hemorrhage, ventricular hemorrhage in the next place. So like that. I don't treat much adults. I usually work in a children patient, but I sometimes do the adult patient too. Yeah.
And one more question before I let you go. Are there any recent developments for the treatment of hydrocephaly, especially in Indonesia? Has there been any recent developments in the treatment?
Yeah, in the treatment of hydrocephalus, we still doing of course, Vipisan, or if the Vipisan is not working, we do the ventricular arterial shunt or another shunt, and then of course we do endoscopic third ventriculostomy for selected patient. Like that, and we do sometimes ADV CPC, but after there's it seems to be the ADV plus CPC became controversial now. No, because I heard from Dr. Kulkarni himself that ADV plus CPC is not superior, and then last week I see the presentation of from the Professor Kulkarni said that EDV plus TPC in the follow-up of long-term follow-up, they can see the ventricle is more smaller in the patient with VP-SAN alone, and the ventricle is larger in the EDV plus TPC. So I don't do EDV plus TPC anymore. I just do EDV in the very selective patient, and if the EDV is failure, I do the VP-SAN. But still, the VP-SAN is our major chosen for VP-SAN. Okay.
Thank you very much for your presentation, Dr. Mirna Sobana. And I want to also thank Dr. Jorge Rera and Dr. Salim Abdulrauf and Dr. Babak Katib for organizing this host. And I hope that our viewers from all around the world have a good morning, good evening, or good afternoon. Thank you very much.
Thank you very much. Thank you very much for giving me this opportunity. Thank you very much, Dr. Salim Abdulrauf and then Dr. Jorge Herrera and all the committee. Thank you very much. Good evening, good night, good morning to all Indonesian fellows and residents. Thank you very much for joining us in this event. Thank you, Dr. Ahmad Assasa.